Good morning, everybody. I would like to present my research result about critical role of RPE in the pathogenesis of diabetic retinopathy. This research result is very important because it changed the current hypothesis in the diabetic retinopathy and may lead to new treatment modality for this disease. I have not any financial interest in this research, but this research is patent pending. Regarding the pathophysiology of diabetic retinopathy, actually during the last 50 years, most of the researchers tried to find the basic mechanism behind the impairment of inner blood retinal barrier, because all of the finding in the retinopathy of diabetes is in the vascular layer. As a quick review, here we have a thickening of the basement membrane of the vessel, and here is the acellular capillary. This is the microaneurysm. And the most important and the first sign of retinopathy is loss of the preside or apoptosis of preside. In this slide, we see how diabetes finally leads to vasculopathy. And there is a different factor. But the most important factor in the pathogenesis of diabetic retinopathy is hyperglycemia. As we see in this table, hyperglycemia directly or through the different pathway, like polyol pathway, pyruvate kinase pathway, poly-ADP ribose polymerase pathway, or hexosamine and AGE product, finally lead to oxidative stress. And this oxidative stress leads to inflammation and also apoptosis in the retinal cell, and it finally leads to acellular capillary ischemia, hypoxia, and production of angiogenic factor and new vessel formation. So the researchers tried to block this pathway to protect the retina from catastrophic effect of hyperglycemia. For example, they used the aldose reductase inhibitor in the polyol pathway, use antioxidant, use anti-inflammatory or anti-VEGF to protect the retina. But there is still one question here. If the hyperglycemia is a major cause of retinopathy, why we didn't see the same finding in the capillary in the brain cortex? Because both tissue have embryologically same origin, and both vascular plexus expose the same concentration of the blood glucose. In this table, we see the differences between retinal and the brain capillary finding in the diabetic dog 5 years after induction of diabetes. And this work done in the UW department by Dr. Ken and Dr. Engerman, one of the pioneers in the diabetic retinopathy research. And in this table, we see microaneurysm, preside loss, and acellular capillary only in the retinal tissue. And in the brain vasculature, we have only a little bit thickening of the basement membrane. To understand the reason behind this discrepancy, first we should know the glucose transport to the retina. We know that retina is a metabolically active tissue, and they need the glucose from the two sources. The one source is through the endothelial cell in the inner blood retinal barrier, and the other source is choriocapillary through the RPE level. If we inject the radioactive glucose in the rat and then remove the same amount of the tissue from the brain and the retina, and we calculate the amount of the glucose in the retina and the brain, the amount of the glucose in the retina is threefold more in the non-diabetic retina in compared to brain. If we induce the diabetes in the rat and then inject the radioactive glucose, the concentration of the glucose in the retina is 4 to 6-fold more in the diabetic retina in compared to non-diabetic retina. At the same time, the glucose level in the cortex remain unchanged. So we should know a little bit about the glucose transporter. Actually, in the first step in the delivery of the glucose to the brain and the retina is transport of the glucose through the barrier. And the major transporter is a GLUT1 transporter. This transporter is a special kind of the protein located in the cell membrane, and they transfer the glucose to the cells and some transporter from the cell out of the cell. And we have a different form of the transporter, but the most important transporter in the cell with barrier function is GLUT1. They are located in the endothelium of the blood-brain barrier, in the blood-retinal barrier, and also in the RPE cell. GLUT2 is located in the liver and pancreas. Other transporters play a little role in the diabetic retinopathy. So in the So in the inner blood retinal barrier, glucose transport through the endothelial cell via GLUT1 to the retinal tissue. And in the normal physiological state, this transporter work in the near saturation level. So increased blood glucose in the diabetic patient have a little impact in the hyperglycemia in the retinal tissue. And interestingly, some researchers show the GLUT1 activity is decreased in the retinal vasculature in diabetic animal. But at the same time, this transporter didn't affect in the RPE or in the brain. So we have a controversy here. We have a higher concentration of the glucose in the retina, but at the same time, the vasculature is not responsible for this hyperglycemia. So we should change our focus from inner blood retinal barrier to the outer blood retinal barrier to find the reason of this hyperglycemia. The RPE cell is located in the outer blood retinal barrier. They are very active cells in the glucose transportation, and the normal physiological state, about 60% of the glucose come to the retina through the RPE cell. And there is a high concentration of the GLUT1 and GLUT3 in the RPE cell, and interestingly, in the diabetes, they didn't downregulate. GLUT3 is not very important as only mediate the basic glucose transport, but the major transporter in the barrier, I said before, is the GLUT1. So based on this introduction, we believe the reason of the hyperglycemia in the early diabetic retinopathy is hyperfunctioning of the RPE cell, and the reason of this hyperfunctioning is hyperactivity of a special enzyme named glucose 6-phosphatase. This enzyme mainly located in the liver and in the kidney, and they play an important role in the hemostasis of glucose. Enzymes have a different compartment, but the major rule is the phosphorylation of the glucose 6-phosphatase and remove the 6-phosphate group from glucose 6-phosphate. Then the glucose is free to go out of the cell. And in the human, we have a mutation of this gene, and this leads to glycogen storage disease type 1. There is a similar enzyme named G6PD, or glucose 6-phosphate dehydrogenase. This is totally different enzyme, and G6PD located in the RBC, and the mutation lead to hemolysis. We should not confuse G6P with G6PD. So we isolated the protein of this enzyme in the RPE cell culture with Western blot here, and also we used immunofluorescence against this protein in the RPE cell culture, and the red area is show the activity of glucose 6-phosphatase. The RPE cell culture is a good tool to test the toxicity of the drug and finding the therapeutical level of the drug before injection in the animal model. And this is a retinal tissue of the human, and we also use the immunofluorescence against this enzyme, and as you see here, the red area is positive for glucose 6-phosphatase activity, and they are highly concentrated in the RPE level. This slide is very important slide in our hypothesis. Based on, if you look at this slide, the glucose comes from the choriocapillary to the RPE cell through the GLUT1 transporter. Then the glucose phosphorylated with hexokinase to glucose 6-phosphate. Glucose can deposit it as a glycogen, or the phosphorylated via glucose 6-phosphatase. And this enzyme located in the endoplasmic reticulum. So the glucose is free, and it can move to the retina through another GLUT1 transporter. We already know in the diabetic patient, we have a 2- or 3-fold increased activity of glucose 6-phosphatase. And also, insulin have an inhibitory effect of this enzyme. So the basic idea is, in the early phase of diabetic retinopathy, we have the RPE hyperfunction due to hyperactivity of this enzyme, and this RPE flux the high dose of the glucose to the retinal tissue. In the other experiment, we cultured the different cells, pre-site endothelial cell and the photoreceptor, and exposed the cell to the high concentration of the glucose. And interestingly, the pre-site is very susceptible to the hyperglycemia, then the endothelial cell, and finally, the most resistant one is photoreceptor cell. And in this report, we found the basic mechanism behind this susceptibility. So it is obvious, if we want to protect the retina, we should decrease the activity of this enzyme in RPE, and we use inhibitor of glucose 6-phosphatase. The only available inhibitor in the market is tialevine, because most of the researchers developed a different kind of inhibitor. But in the systemic application for treatment of diabetic type 2 cause glycogen storage disease, so it's not commercialized yet. In the research, we used a special kind of the mouse named is TSP knockout mouse. In the normal rat and mice, it takes about 1 year at least after the diabetic induction to show off the capillary involvement. In the dog model, we need 5 years. In the monkey, maybe 10 years. But in the special mice, thrombospodin 1 mutant mouse, developed in the UW and Dr. Shaybani lab, they are very valuable tool for checking the drug treatment in the diabetes. So we use this kind of mice and inject the STZ to destroy the beta cell of the pancreas and induce diabetes. And gradually glucose rise above the 250. And after the 1 month and stabilization of diabetes, we inject the first dosage of inhibitor intravitreally. And the second dose, 6 weeks after the injection of the first dose. We wait 3 months, and after 3 months, we remove the eye and prepare the retina with trypsin digest method and stain with hematoxylin, eosin, and PAS. In the retinal flat mount, we are looking to see the two kind of the finding in the diabetic retinopathy. The first finding is counting the endothelial cell and the precyte cell. As you see here, the endothelial cell is elongated cell located inside the vessel. The precyte is smaller, denser, and outside the vascular wall. So in the 4 quadrant of the retinal section, in the middle part of the retina, we count endothelial to the precyte ratio, and the earliest sign of retinopathy is the precyte loss. So increasing of the ratio is due to the diabetic insult. And in our model, we see the protection of the precyte in the treated group in compared to control group. The other factor is looking to the acellular capillary in the capillary bed. And if we compare the acellular capillary, the flash area, in the control group with the treated group, we see that we have a significantly protection from acellular capillary in the treatment mice. So based on this finding, we believe in the diabetic retinopathy in the early stage, we have RP hyperfunction due to G6P hyperactivity, and the reason if we can block this enzyme in the long term, we can protect the retina from catastrophic effect of hyperglycemia. It's interesting to know that in the patient with retinitis pigmentosa, it's very rare to have a diabetic retinopathy. And the other factor is we use the non-competitive blocker of glucose 6-phosphatase. And it's not a physiologic because it totally blocks this enzyme and maybe in the long term lead to chorioretinal atrophy. So we should synthesize the new inhibitor with a competitive inhibitor. We only need to decrease the activity of this enzyme in the RPE, not totally disrupt it. And the other idea is using the laser for the treatment of the retinopathy. Currently, we use the threshold laser to protect the retina from advanced retinopathy. But based on this finding, if we apply the laser in the early stage of diabetic retinopathy in the subthreshold level and only attack the RPE without destruction of the photoreceptor and scar formation, it also can protect from the retinopathy if we apply the laser very early stage before the vascular damage. But it is obvious if we wait to see the vascular injury, we see this ischemia hypoxia, we should apply the threshold laser in that case. And I would like to acknowledge Dr. Shaybani and also his researcher, Dr. Albert and Dr. Sorensen, for helping in this research. If you have any question.